Okay, good afternoon to you all. Welcome to this sixth webinar on COVID-19. The aim of this webinar is to share information and guidelines to all healthcare workers in and across Botswana. So the webinar is co-organized by the Ministry of Health, University of Botswana, the Botswana-Harvard Partnership, and Rutgers University. My name is Vuylsteke. I'm a medical oncologist at the Faculty of Medicine and Princess Marina Hospital. Before we start, there's some housekeeping. Please mute your microphone if that's not done yet. There will be a possibility to ask questions through the chat function, and this one, it will work because it's Zoom this time, and a moderator will monitor your questions. The session will be recorded and will be made available after the session. There will be a feedback survey mailed to you. Please give us suggestions on what to improve and what topics you would like to have in the future. So we have three speakers, and the first speaker is Dr. Rebecca Luckett. She is an obstetrician gynecologist at the University of Botswana and Princess Marina Hospital. She came to Botswana in 2016 with the Botswana-Harvard AIDS Institute partnership and worked at the Scottish Livingston Hospital for 3 years before joining UB in 2019. She's also faculty at the Beth Israel Deaconess Medical Center and Harvard Medical School in Boston. Rebecca, please.
Thank you, Peter. So we'll start our conversation on COVID-19 and pregnancy. And just to preface the conversation, we have divided guidelines according to pregnancy, neonates, and pediatrics. So there will be more information to follow on what to immediately do with the neonate in the coming presentations. And also this presentation is intended to be concise and to address particular issues related to pregnancy, not to repeat information that's already covered in the other general ministry guidelines. So one thing that we've learned about COVID-19 is that it doesn't seem to behave differently in pregnant women than it does in the general population. So there's two relatively large case series of pregnant women with COVID-19, and what you can see from these numbers is that essentially women have the same rates of severe disease and critical disease as the general population. Now, that being said, severe disease is quite dramatic, and it can appear quite dramatic in pregnant women with very high rates of tachypnea and hypoxemia. And so we do have to keep that in mind as we're managing their pregnancy. And an important note is that up to 1/3 of women who end up being diagnosed in the peripartum period actually present to the labor ward or to the obstetric, the antepartum unit, asymptomatic. And so that's something to just keep in mind when you're encountering pregnant women and in your hospitals and clinics. Pregnant women have similar symptoms to other people with COVID-19. So fever and cough are the prevalent symptoms, followed by shortness of breath, myalgia, sore throat, and malaise. They have similar laboratory findings, with lymphocytopenia being very common. And in terms of maternal and neonatal outcomes, there have not been an increased risk of associated maternal death or neonatal death or IUFD, as far as we can tell from what's been reported in the literature to date. So in general, any pregnant woman coming into a facility should be screened according to Ministry of Health facility guidelines. And for us, we realized in Marina, for instance, that many of our pregnant women are somehow bypassing the general screening tables that have been set up. So in fact, it may mean at your facility that you need to be rescreening women when they come to your labor ward or to your clinic, depending on what your facility setup is. While they're waiting for their visits, they should be spaced 2 meters apart, and they should be in well-ventilated areas while waiting. Again, I repeat this concept that we should think of labor ward as an A&E in terms of potential exposure to asymptomatic carriers and sort of new admissions to the hospital. Testing of subjects should be done according to your facility protocols. In Marina, that is dialing the 997 number, and you can follow your DHMT guidance in your particular facility. Particular to the obstetric services is that we have to be sure that we've created isolation areas for COVID suspects and confirmed disease. So this means on our antepartum, labor ward, and postpartum wards, we need to have a room designated for patients who are confirmed COVID-19, and we should have a separate room for a suspect with COVID-19. And just to reiterate, a suspect should not be roomed either with a confirmed positive case, nor with a known or a patient who's not even a suspect for COVID-19, because you obviously don't want to risk contaminating or infecting a patient who otherwise wasn't a suspect. So in terms of personal protective equipment in our units, so obviously screening all patients when they enter a unit, you should have a surgical mask plus eye protection. Those are the ministry's guidelines. Now, when caring for a non-COVID pregnant patient, you can just wear a surgical mask. Once you're caring for a patient that's a COVID suspect or confirmed case, you have the surgical mask, your eye protection, a waterproof gown, and gloves, which is all in line with the ministry guidelines. And then one thing to note is that we don't have good data, but there is suspicion that the second stage of labor could be a potentially aerosolizing procedure, if you will. And so we do recommend use of an N95 mask when caring for a COVID suspect or confirmed case in the second stage of labor. And then obviously all patients who are COVID-19 suspects or confirmed should be wearing their own surgical mask. And if they're on oxygen, you can place that mask over their nasal cannula or over their oxygen mask. I think we can skip through, yeah. So when you're referring or a facility is preparing to receive, there are a few things to keep in mind to prepare your unit. So the first thing is when you're sending a patient who's a suspect or a confirmed case to a labor ward, you need to notify the receiving hospital in advance because they're going to need to make some particular preparations. And obviously, when you're sending the patient off, you should ensure that they're wearing a mask. So the supervising midwife at a receiving labor ward needs to make the following preparations. So first, one midwife per shift should be assigned to exclusively care for a COVID-19 patient. And this is because we know labor wards, they're fast-paced environments. We often are moving quickly from one room to the next. And we need to make sure that we don't accidentally contaminate another patient's clinical environment. We should designate an isolation room for that patient to occupy, and that room needs to have oxygen, hand washing facilities. And we do recommend that you place a sign that clearly reads COVID-19 on the door so that not only the clinical staff, but also our healthcare auxiliaries and our environmental services staff are also aware of that precaution. The room should be supplied with nasal prongs, a face mask, a dedicated stethoscope, a dedicated Doppler, and then a facility for the patient to void and to defecate, so whether it's a bedpan or a bucket. And all of these items should stay inside the room during the duration of the patient's, that the patient spends on your unit. And then one important point is just PPE should be placed close to the entrance to the door for that patient that is a suspect or a confirmed case of COVID-19, so that the care providers who need to access her, and sometimes we know in labor we need to access them quite quickly, has the equipment that they need immediately available to them to enter the room. So in terms of admission, sort of good clinical practice is obviously, again, ensure the patient's wearing a mask. Before the midwife who is taking care of the patient interacts with the patient, she should don the appropriate PPE. You should clear other patients and staff from the entryway into the patient's room, and then the patient should go directly to her room. While you notify the doctor on call, the midwife should immediately take vital signs, including temperature and oxygen saturation. And for pregnant women, we recommend maintaining an oxygen saturation of 95% or greater. And so oxygen should be placed on the patient to maintain those saturations. We recommend checking the fetal heart rate with a Doppler, and if feasible, you can put on a CTG. And then the baseline bloods that we recommend for the midwife to collect are an FBC, RFTs, LFTs, and a coagulation profile. If testing hasn't been done yet, then you should mobilize your hospital's mechanism for testing. And if the patient is in labor, then you need to notify the pediatrician so that they can make appropriate arrangements to receive the neonate. So good general practice that we recommend is keeping the file that you're using to document for the the file and the pen, everything you're using to document for the patient inside that patient room, so that we don't contaminate the other surfaces on the labor ward. And as we said, we recommend the stethoscope and Doppler stay inside the room, but if you need to bring them out, they need to be sanitized when you bring them out according to infection control standards. When the health worker leaves the room, he or she should remove their gown and gloves inside the room and wash their hands before touching any other surface. And then it's recommended for the midwife who's caring for the patient to leave their mask and eye protection on as long as they can during a shift, obviously taking it off for eating and drinking. And the ministry does recommend changing the mask every 6 hours. And then finally, just ensuring that we have a high standard of environmental hygiene is really important in this setting. So in terms of patient management, I think one of the questions that had come through before the webinar was, where do we isolate patients who are confirmed pregnant? And the first piece that we have to take into consideration is whether the patient has a viable pregnancy or a pre-viable pregnancy. And in general, in Botswana, we use the cutoff of 28 weeks gestational age as the cutoff for viability. So we've basically said if a pregnant patient is less than 28 weeks, who's not, so we consider her non-viable and not in labor. The first piece is that we have created a designated Circuitumile OB COVID consult team, so that we're always available to you should you not be sure where you should send a patient. But generally with mild disease, you should contact the DHMT for isolation in a suitable facility or for home isolation if they're a reasonable candidate. For moderate to severe disease, they should go to Circuitumile, or in the future, if there's another COVID-19 treatment facility, they could go to a closer COVID-19 treatment facility. Now, if that patient were to develop an OB complication, have a miscarriage, or develop preterm labor, we generally recommend that a patient with mild disease can go to their closest district or primary hospital for management. And a patient with moderate to severe disease, which currently would be managed at Circuitumile, they would either continue to be managed at Circuitumile or at the closest referral hospital. So one thing I'll just mention before we continue on, I think a lot of people are wondering, well, why wouldn't we just deliver patients or manage complications in Circuitumile? And unfortunately, Circuitumile really doesn't have the equipment to run a labor ward, nor to have operating facilities. And so while we can do maybe very basic management there and fairly good medical management, we aren't able to offer the full labor and delivery services that we can offer at our referral hospitals. So now we'll talk about where do we isolate patients who are more than 28 weeks pregnant and who are not in labor. So again, we ask you to please notify us first thing off when you have a patient who comes in. Patients with mild disease, again, you can contact your DHMT so that they can be isolated in a suitable facility. And we would recommend that they're monitored in a facility as opposed to in their homes, so that they can continue to have fetal heart checks. If they have moderate to severe disease, then the first piece is to call the consult team so that we can assess whether it's in the best interest of that patient to expedite delivery. And we'll get into that a little bit later about thinking through that decision. But generally, those patients with moderate to severe disease that need respiratory support can be sent to Circuitumile, or again, in the future, a designated COVID hospital. Again, those patients will need fetal heart checks. So if they're in a designated facility and they develop labor or an antenatal complication, then the same principle applies, that they should be sent to their closest facility. So a patient with mild disease can go to their local district or primary hospital for management, and a patient with moderate to severe disease, who as of today would be at Circuitumile, potentially in the future in a different hospital, they should go to their nearest referral hospital. So we've developed some simple, I hope they're simple algorithms to help guide the decisions that you're trying to make. And I won't go through these in detail. I know they're a bit difficult to read from through this PowerPoint presentation, but essentially we're thinking about two things with pregnant women. One, are they in labor or have another obstetric complication or they're not in labor, and then 2, what level of disease do they have, and that's going to guide where you send them. I think we can skip through this. So there's an algorithm both for primary and district hospitals as well as referral hospitals. So in general, for patient management, now the ministry has very good guidelines on how to manage a patient who is COVID-19 positive. A couple of specifics for pregnant women. One thing to remember is pregnant women can get chest x-rays. The amount of radiation that a pregnant woman might be exposed to, or the fetus might be exposed to during a chest x-ray, is absolutely safe in pregnancy, and it shouldn't be restricted because of her pregnant status. Supplemental oxygen or respiratory support, we have sort of higher cutoffs in pregnant women, and we do recommend a cutoff of 95% to ensure that you have adequate placental oxygen perfusion. We know that we always try to keep women on their side, so left lateral decubitus position is an optimal position. And Dr. Clune last week spoke about the benefits of proning patients, so actually putting patients face down essentially. And people have been doing that also for pregnant women. You can either affect that through sort of an extreme lateral decubitus position or by propping up a pregnant patient's abdomen with pillows. We do recommend getting a baseline CTG if the patient is greater than 28 weeks and consider additional monitoring depending on the clinical situation. We also support the recommendation to prescribe low molecular weight heparin for DVT prophylaxis. And otherwise, the sort of other supportive care, I think, is in line with our general guidelines. And then just the last thing is, again, please don't forget, we need to notify our pediatricians in advance of the delivery so that they can make appropriate preparations. So the question of expedited delivery, it's really, there's not a hard and fast rule on this, and we really need to consider the clinical situation. So one is whether or not there's an obstetric indication for a delivery. Other conditions are that other things that you might consider are that patients with severe or critical disease, their oxygenation status might improve with delivery, and they have seen that in other sites. And so that's why we do recommend that you consult with the OB team if you have a patient with severe or critical disease, so that we can make the best decision around whether to expedite her delivery. So in general, for antenatal care, there are some facility recommendations that we have and that we have implemented at Princess Marina, for instance, to decongest our clinical sites and still provide safe care to our pregnant women. So the first is that your initial booking visit obviously should happen as soon as possible. And after that, you can space your visits to every 6 weeks until the patient's 32 weeks pregnant. After that, you can have them do every 2-week visits. That's obviously as long as everyone is well. If any complications develop, they should be seen more frequently. We recommend that the sexual and reproductive health sort of referral clinics don't accept walk-ins, and we really recommend that all pregnant patients are referred via a phone call from a healthcare provider. Because what we've actually found is that a lot of the issues and questions that people have can be solved through a phone consultation. And then the last piece is that patients, obviously, who still need to be seen and admitted are patients with preeclampsia with symptoms, patients who are 41 weeks who need to be induced, and patients who are planning for a trial of labor after cesarean section who maybe live in a remote area where they don't allow TOLAC. Rather than sending them at very early gestational ages, we recommend sending them closer to the time when they're more likely to deliver. In terms of how to manage in the antenatal period a COVID suspect, so one, we recommend that they suspend their care until they have a negative test result. For a COVID-19 confirmed patient, we recommend suspending their routine antenatal visits unless they develop an issue. We also recommend prescribing prophylactic Clexane during their disease and then 14 days of recovery. And we also recommend an ultrasound to assess fetal growth 2 weeks after they recover. And then one other question about timing of delivery is you can consider delivering a woman at term who's diagnosed with COVID-19, and it might be useful to deliver a woman while she's well with COVID-19 so that you're not trying to manage a delivery while the patient is crashing from a respiratory standpoint. We've had good success at Marina in expediting our postnatal discharges. So we've implemented a policy of discharging women who've had normal vaginal deliveries after 6 hours. We've also been able to expedite deliveries for routine cesarean sections without complications on day 2. It does require some attention to advancing diet a little more quickly than we're used to, but which is safe, and to collect their routine bloods earlier than maybe we otherwise would have. And then we do recommend that women come in for their postpartum visit. It's an important sort of general health visit, and it's really important in this time because other services that people may have difficulty accessing, for instance, cervical cancer screening, it's an important time to sort of maximize the care that we can offer women. And another thing that I didn't mention here is screening for intimate partner violence. We know that our rates of gender-based violence have increased in this time of COVID. And so the postnatal visit offers an opportunity to screen women for that and offer them services. I won't spend a lot of time on the gynecologic care, but just to mention, we've had good success with expediting evacuations and discharges of women with incomplete abortions. So generally, if they're not septic, we've been able to use a paracervical block, use a manual vacuum aspirator, and discharge the patient 2 hours after the evacuation. So just a few facts to finish up. So first, does COVID-19 lead to worse pregnancy outcomes? So as I mentioned, it doesn't seem that it does. You may have seen in the literature that there is a slightly higher rate of preterm birth among COVID-19 women, but we believe that's mostly iatrogenic, and we're choosing to deliver women, or we're having to deliver them early because of COVID disease. Should timing of delivery be impacted by COVID-19 infection? And that's the answer to that is possibly, right? So we could consider expedited delivery given the maternal oxygenation status, or if they're at term, we might consider delivering them earlier. So do pregnant women with COVID-19 need a cesarean section? Not necessarily. We do generally see that we need to lower sort of our cesarean section threshold with COVID-19 simply because women with moderate or severe disease, let me say hypoxemic women, when they try to Valsalva during the second stage of labor, they can have extreme desaturations. And so it might not actually physically be possible for a woman to push while she has moderate or severe disease. Can we give pregnant women with COVID-19 antenatal corticosteroids? And the answer to that is possibly. It really depends on the situation. So if a woman has mild disease, and she has a good obstetric indication before 34 weeks, then we can still give antenatal corticosteroids. But I would recommend withholding steroids in a patient with severe COVID disease, as it's been associated with worse outcomes. And then one other question, can women with suspected or confirmed COVID-19 continue aspirin if they're on it for prophylaxis? And the answer to that is yes. There's not enough evidence that NSAIDs worsen the disease process. So we know that, the difficulty in getting patients to higher level care has been a problem, and this will all be shared in the guidelines, but we're trying to launch on the OBGYN services, the Vuylsteke app. So this is a South African consultation app where general providers or even specialists can request online or through the app consultations of other subspecialists or specialists. And so we're trialing it out now. A number of the specialists are registered with this app, so feel free to download it, and we can try to support you as to get us to maintain care to the patients who need it. And that's it. This is just a thanks to our guidelines committee and the names of the consultants at UB who formed the OB COVID consult team.
Thank you very much. Now we will a little bit change the scheme, because after delivery come neonatology. So we have a presentation on neonatology by Professor Britt Nakstad, who is a neonatologist and has been a professor in pediatrics for 17 years at the University of Oslo in Norway. and is now at UB, University of Botswana, since November 2019 as professor and head consultant in neonatology. Her research interests are in newborn resuscitation, premature nutrition, and breastfeeding infections. There will be a possibility to ask questions live after the 3 presentations. Thank you.
Hey, thank you for the kind introduction. Do you hear me? I'm not in your room. So before I start, I would like to describe the neonatal population and the patients that I'm gonna be talking about. As neonates are newborn babies up to day of life, 28 days, and we even have patients that stay in the neonatal unit for a much longer time. So before birth, the baby depends on functions from the mother. These include breathing, eating, elimination of waste, and protection. And when the baby leaves the womb, its body system must change. For example, the lung must breathe air, the cardiac and pulmonary system changes, the digestive system must begin working to balance fluids in the body and excrete waste. An immune system must begin working by its own. So the baby may have trouble making the transition outside the womb. Preterm birth and difficult birth defects can make these changes even more difficult. And these babies are exactly the ones in neonatal units that need neonatal nursing and intensive care. But also add that the neonatal death rates are surprisingly high in Botswana. Each month they range from around 20% to up to 40% in February 2017. And this is very high. And of course it has many causes. But just to mention that irrespective of COVID-19 or not, we have high death rates in the neonatal wards. So the data on COVID-19 in neonates are rare. There are some studies done, especially in China, and in each slide you will see the references at the bottom. Also an interesting study from Spain. So mother-to-child transmission of COVID-19 during pregnancy is unlikely, according to most reports, and it has not been reported yet. After birth, a newborn can be infected after exposure to an infected person, maybe the mother or another caregiver, the father, for example. So based on this limited published reports, a very small number of babies have been tested for the virus shortly after birth. And those who showed to be positive, we don't know if the virus was there before birth, during, or after birth. So now to the neonatal guidelines. I've decided to divide these into separate sections. And the next slide would be that, the next slide. Yes. So our recommendation would be that there should be one designated doctor and or midwife, preferably both of them, assigned to each delivery where the mother has suspected or confirmed COVID-19, and one doctor and midwife per shift. So there should be a dedicated room for these deliveries and another room close to this where the mom and baby can stay if the baby is sick and needs neonatal care. These rooms should be marked as COVID suspected or confirmed cases inside, and all the necessary equipment like the ventilator, papers and pens from stethoscopes and everything should be inside the room and not moved out from this room, of course. And washing hands very, as of course, uppermost important gain. The doctor, midwives, nurses should use PPAs for contact. Droplet and airborne are, of course, mandatory in these rooms. So the next slide. As you know, neonatal resuscitation includes aerosol generating procedures. So where neonatal resuscitation is required, either immediately after birth or during the stay in the neonatal ward, PPA must be there. Suction, as you know from international guidelines, suction in breastfeeding is recommended if the baby is not in respiratory distress. I see that it's often done at deliveries, but it's not meant to be routinely done at birth. But of course, in the wards, we suction the babies all the time. There's lots of secretions, needs to be during nighttime and everything. And this is very difficult to wear the PPAs during these procedures. So, also, the newborns requiring respiratory support should be transferred to the NICU immediately after delivery and in the isolated area that should be there. We are happy at Princess Marina Hospital. We have such a room now for delivery that is very close to the neonatal unit, and it's also very close to the room where the mom and baby can stay afterwards. So, when should we test these babies? Neonates born to mothers with COVID-19, either it's suspected or confirmed, should undergo this testing on nasopharyngeal or pharyngeal samples within 24 hours after life. If the initial sample is negative, this testing should be repeated. This is among those who have reported COVID-19 in neonates, but this is our recommendations. So if the initial sample is positive, we should also repeat this testing at 72 hours until we have 2 negative ones. And then I separate between babies and sick babies, because babies and preterm babies weighing more than 1,800 grams at birth and who require minimal care should remain with their mothers in separate isolation rooms, as I already mentioned. And the mothers should wear a mask and wash their hands very frequently with water and soap. We even recommend skin-to-skin care with these precautions. If the mother is very sick, all these things like feeding, changing the napkin and so on should be done by the midwives or the nurse caring for the patient. If the baby is sick and we suspect that, should immediately test by a doctor after delivery. And this doctor determines the required level of care and put the baby in the isolation room or an isolate. So that so the inpatient management. We suggest that babies, if there are more than one, should be managed as a cohort in a separate isolation area with with 1 to 2 meters between the cots or the isolates. Preferably, the babies should stay in the incubator one. Minimize the transmission of COVID-19. The clinical investigations should be minimized while maintaining standard care. Sometimes we may do too much, and in these cases, maybe we should try to minimize the handling of these babies and do the necessary things. So we should also have closed suction system, because this is very aerosol provoking systems and fear of transmission. But I'm not sure if we have them in Botswana. I haven't seen them yet. So that would be a Christmas wish. So, and again, the PPAs should be worn, of course, whenever we do aerosol generating procedures and therapies, nebulizer treatments, and high flow oxygen treatment. So the last slide, where I've got a lot of questions already, is on breastfeeding. It's the last one. So this virus has not been detected in breast milk or confirmed COVID-19 patients. So we suggest that women should be encouraged to continue breastfeeding while practicing respiratory hygiene and wearing a face mask. This is true for healthy babies and sick babies. Women who are too young to care for their babies should be assisted to express breast milk, and this milk should be given to the baby. The babies or the mothers should have a dedicated breast pump to use to express milk. These are available nowadays and easy to use. When doing this expression of milk, they should probably wear a cloth covering themselves during expression to minimize transmission of the virus. So, if possible, if the mother is sick, this expressed milk should be provided to the baby by a health giver, a health personnel that is not at high risk for severe illness from COVID-19. So this would be the end of my talk. And thanks to the COVID team at the Department of Pediatrics and Adolescent Health, Dr. Mulale, Dr. Strisco, Damon, Dambi, Patel, Dr. Joel, and I hope I didn't forget any of these. And not at least the mom in the picture here, who gave written that I could present this picture with the baby in kangaroo mother care to you today. So thank you.
Okay, thank you, Dr. Nakstad. We now go over to the third presentation with, again, issues on pediatrics, who will be given to us by Dr. Unami Mulale. She is a pediatric intensivist and pediatric global health practitioner. She is the Assistant Program Director of Pediatrics at the University of Botswana and currently leads the pediatric COVID-19 task team.
Afternoon. So hopefully my section will be brief because kids don't get sick and die from COVID-19 as often as adults. So, you can go. So basically reports on children and COVID from all over the world, Europe, the US, China, all say the same thing. Kids have a lower attack rate, so they get COVID-19 in less numbers and they get less symptomatic disease. So most kids actually present asymptomatically or with mild disease, but the commonest symptoms will be fever and cough. There is a subset of kids, a significant number, about 10%, who present with non-respiratory symptoms whatsoever. So look out for those. They also get less lab abnormalities. So their white counts are usually normal. The inflammatory markers are only slightly raised. The x-rays may have mild infiltrates. The chest CTs can also be normal. The thing about this disease, though, is that x-ray wise, it presents just like any other respiratory virus. So the issue with this in our setting is that we are not currently doing any other respiratory viral tests. And we know what we are going into the winter and kids are gonna get sick and then we're gonna panic. Is it COVID, is it not? It's likely not, but there's no way to tell unless we are tested. We don't know what the role of kids in transmitting the disease is. We know they don't get the disease as often. We know they get more asymptomatic disease, and the question becomes, are they transmitting the disease when they are asymptomatic? And that answer is unclear. I think there's only been one study that has suggested that they may be transmission, but it's inconclusive. These are the case definitions and they've been discussed elsewhere, so I'm just gonna skip over this slide and this slide. They are not dissimilar from the adults' case definitions. So when you have a child that presents and you are worried about COVID, please, well, the current recommendation is for everybody to wear cloth masks. We don't recommend a mask in 2-year-olds and below because there's suffocation risk, but you can certainly place a mask on the parent. Wash your hands or sanitize with alcohol-based hand gel, and don the appropriate PPE. So if you are going to not be doing an aerosol generating procedure, then that's just a surgical mask, goggles, waterproof gown, and gloves. You are going to assess the child looking ABCDEs, right? So you're looking at their appearance, you're looking at their breathing, and you're looking at their color. And please don't forget to always check for dextrose. If there are any life-threatening issues at presentation, please deal with those. But make sure, again, that you're wearing the appropriate PPE. One of the first things you're going to do after looking at the child and assessing them is their vital signs. Remember that pediatric vital signs depend on age. Your heart rate and your breathing slow down as you grow older. So it's really prudent for every place to have a chart of normal ranges of vital signs and to know what to do with those vital signs. Once you check those vital signs, you can do a pediatric early warning score. This is essentially going to tell you, is the child critical, right? So the chart here shows you how abnormal the vital signs are. So from green all the way to red is vital signs becoming more abnormal. Again, you're looking at the breathing, you're looking at their cardiovascular status, and you're looking at their neurologic status based on their behavior. Are they irritable? Are they playing? Are they calm? What are they doing? So if you do an early warning score, you then will know what to do with the child. So this is an algorithm of what to do. So you do an early warning score, you have placed, well, the child has come, you've looked at them, they look good, you've placed them in an isolation area, the early warning score is green, they have just a simple cold-like illness, no signs of pneumonia, you can then send your COVID test. We're on the green limb of this. You can send your COVID test, you can contact your DHMT for isolation, and the child is happy and fine. You can decide whether if there's an isolation place that they can go to, or if they're all being isolated at the hospital, then you just send them to an isolation area and they can be happy. So if their Q score is between 3 and 5, they're in the orange area. The question is, do they have pneumonia? Do they have viral pneumonitis? They need to be watched more closely. So you then do your physical exam, you still send your COVID testing, you admit them to a ward where you can monitor them every couple of hours, and you keep reassessing your early warning score. Because viral infections in children predispose to bacterial infections, if you have a suspicion for pneumonia, remember that one of the #1 killers of children in our setting is pneumonia. Consider IV antibiotics or oral if they can tolerate oral, and make sure that you manage that fever. As you're monitoring them, should their early warning score rise above 6, you now have an issue. You need to escalate their care. So what you would do then is consider, do they have ARDS? I think there's a slide coming up that's going to tell us what ARDS is, but do they have ARDS? And we are now in the red limb. So back to where we were. Yes, right there. Right, so in this case, you're going to send labs, and our labs that you're sending, again, the swab for COVID-19, then you're going to send your FPC, your user-knees, do an X-ray, start them on some oxygen. What mode of oxygen to start them on depends on their vital signs and what they look like. But essentially, remember that high-flow nasal cannula or CPAP, like our non-invasive modes of ventilation, are potentially aerosol generating. Often when there's wheezing, we'll nebulize, but remember also that's aerosol generating. So if you have a meter-dose inhaler with a spacer, you can use that. Transfer them to the ICU if you think that there's ARDS. ARDS means you have bilateral changes on chest X-ray, you have hypoxic lung failure, and you have non-cardiogenic pulmonary edema. If you're going to intubate, remember that intubation is aerosol generating. You need an N95. There's no single mode of ventilation that's best. So the usual things that we preach about ARDS, small tidal volume, high PEEP, is how we are going to treat them. The goal of mechanical ventilation is to actually improve gas exchange. You want to improve delivery of oxygen, which will improve their hemodynamics. So the sicker they are, you are going to tolerate lower SATs, 88, and you're going to tolerate lower pHs. As long as they're hemodynamically stable. If they're hemodynamically unstable, you have to play around with those numbers a little bit. If you have to put them on the vent, remember that it's greatly, greatly uncomfortable, so please sedate them well. Benzos and opiates are first choice. We may add neuromuscular blockade if it's difficult to sedate them. If they're hemodynamically unstable, you're going to tolerate lower hemoglobins because transfusion has its own risks. But if they're stable, you tolerate lower hemoglobin. If they're unstable, you augment oxygen delivery by giving them transfusion. I always say this, guys, IV fluids are not benign. If the gut works, use it. So your daily fluid intake should maintain your intravascular volume. And you always replace with an isotonic fluid initially, Ringer's lactate or normal saline. Once you achieve improvement in your hemodynamics, you can choose HAF-DD, DMS, even Ringer's lactate at about 60 to 80 ml per kilo per day. Remember that you don't want to flood the lungs. The lungs are already flooded. So you want to protect the lungs from further pulmonary edema. So you are going to put an NG tube, feed them, and every single one of these patients should have a nutritional plan. Monitor your urine output and alter your fluid intake and your enteral intake based on your urine output and your renal function. So extubation readiness, there isn't a universal or uniform guideline for taking patients off the vent, but they should at least demonstrate some reversal in the reason why they were intubated, and they must be breathing spontaneously and be hemodynamically stable. If you're satisfied that they're well enough to get out of the ICU, you can get them to a step-down unit, you can get them to the ward. You definitely have to collaborate with the family about your projected course towards discharge home and have a clearly laid out plan. So importantly, please remember, this still says 1 to 2 meters, but I think we're saying 2 meters apart. Please remember, social distancing is very important. How you get COVID is either you touch it or you breathe it in. So always, always remember to wash your hands with soap and clean water all the time. There should be no visitors allowed. So what we are doing is having one parent at the bedside and one other visitor just in case the parent needs some sort of something from home. And remember, cloth masks always.
Okay, thanks very much. Now your microphones will be unmuted now, so there's time for live questions. Is there any question from the audience? While we are waiting, I have a question for Dr. Rebecca. For the patients that are over 28 weeks and suspected are a COVID-19 suspect, they should be taken care of in a special unit provided by the DHMT because they need monitoring. So what if there's no monitoring possible in that unit because it's not necessarily a hospital where they will be?
That's a good question, and I think the answer to that really comes down to the DHMT plan for patient isolation. So I think right now the answer to that would be that they would come to sick community. But I think in the future, depending on what happens with the disease, then they may be able to keep them in their own districts. I don't know if that answers. Yeah, I think it'll just take a little bit of ongoing collaboration with the DHMTs.
All right, thanks.
There was one question that came through before the presentation regarding universal screening of pregnant women. And I think that came out of, there was several labor units in cities with high community transmission are doing universal testing for all women when they come into antenatal units. And that was where a lot of the numbers came from, that case series in New York, which showed that 1/3 of women were asymptomatic but PCR positive at the time that they came in for delivery. So I think that strategy would make sense if we see that we have high rates of community transmission. But I think in the absence of high rates of community transmission, it's not a policy that's really going to be necessary in our labor units.
Okay, thank you. I see there's a question through the chat who wants to know if the caregiver wears only the mask for full PPE. Last slide of the presentation. So if the caregiver wears only the mask or full PPE in the last slide of your presentation on pediatrics, I suppose.
No, the caregiver, you know, where's, is it okay to answer from here?
I don't know.
Okay. Sorry. Caregivers wearing the mask is to basically stop the spread of aerosols to the people around them. They're not going to be attending to anybody else, so they don't need full PPE. So they just need a cloth mask as recommended by MOH. That's all they need.
Right. Our microphones are working and I don't hear any questions. Is there any questions from the audience?
Hi, could I just follow up on the question I put on the chat?
Yes.
It's Sunanda. It's just this issue about, you know, that in a way, because we think of an infectious disease, and also I guess because we're used to working with HIV, that you think that once somebody has got it, they've got it. But in fact, this is an infection that people recover from. So I wondered where, you know, I've got an answer from Vuylsteke about it, but it's just, I suppose people need to be reminded that they would need to have a second PCR or 2 PCRs to say that they're recovered. But once that happens, then they should be treated like anyone else, yeah? That they would no longer be infectious, so they don't have to go through that whole process that Rebecca described. But they would need to have PCR testing.
Yeah, thank you for that question. And I was actually responding on Dr. Halate's computer to that. But essentially here, before they're discharging people right now from Sukatamile, they are getting a PCR test. And so I think once a patient has clinically recovered and they have a negative PCR test, we can assume that they're negative and treat them like a regular patient.
Yep,
Oh, sorry.
thanks.
Someone's adding a double negative. We're doing 2 PCR tests.
Any other questions from the audience?
This is Doreen.
Hello.
I don't have a question. It's just to just say well done to the 3 presenters. I think we've had quite a lot of questions regarding obstetric patients coming through our various means over the last few weeks. So it's good that we finally managed to get this presentation going. So thank you very much to Rebecca, to Prof. Nasdaq, and to Dr. Mulale.
Thank you. Yeah, you're absolutely right.
Yeah, this is Dr. Joel here. I also don't have questions, but again, mine is just the comments to say well done to the team, Dr. Mulale, Prof. Nasdaq, and the OBGY team for this guidance. Just a little thing is just in terms of as more and more literature is coming out of this condition, there has been some studies that have came out that the autopsies that were done in Italy were showing that this condition is not the typical ARDS as we know it, but there must have been some form of interference of the virus at the alveolar level in terms of the absorption of oxygen. So I don't know whether Dr. Mulale maybe you want to just make a comment on those preliminary findings, or what's your take on that?
Can you please present yourself?
Sure.
Okay.
Hi, Dr. Joel.
Yeah.
So I have not really gone through that data in much detail. So I'm sorry I can't answer to that question. So I think we are learning a lot as the various reports come through, but I haven't spent much time in looking at those reports.
Okay, thank you.
Hi, Peter.
Yes, hello.
Can I just add a comment on to Dr. Jewel's question?
Yes. Can you please present yourself for the audience?
Oh, my name is Dr. Palai. I'm one of the physicians at the Princess Marina.
Yes.
Yeah.
Please go.
So if you read on Professor Luciano Gattonini, who is a very well written on ARDS, the autopsies that were done, they are describing microvascular thrombosis in the alveoli, which is why there's been a hot topic around thromboprophylaxis. In fact, they've spoken about, increase in doses from twice a day to as much as 4 times a day. On top of that, they've also described as cytokine storm syndrome, which a lot of these patients that require high FiO2s are found to possibly die from ventilator-induced lung injury, something called a Vili vortex, in which it's a vicious cycle from which a patient reaches a point where it's difficult to recover from. But as Dr. Jewel said, there's more and more data that is coming out. But if you look at his papers, he's published quite a number of papers over the last 3 weeks or so to describe the pathophysiology of the ARDS.
Dr. Palai, can you please help us in which journal that paper is?
There's quite a few, but I would advise that if you Google, unfortunately, I don't have it here with me now. If you Google Professor Luciano Gattonini and ARDS, COVID-19 ARDS, a couple of papers will come out.
Dr. Palai, that data is in adults, correct?
Yes, this is in adults, I must say.
Yeah, yeah, I don't think we have enough data actually in children, because there's literally less than 1% of kids that die from this. And I don't think there's been any autopsies in the kids that have died, or at least nothing published on that.
I see there's a question through the chat for Dr. Nakstad. Somebody who wants to know, actually Dr. Gabelo Tamai wants to know why neonates are swabbed every 3 days. Dr. Nakstad?
Yes, I had to unmute myself. Why they have to be swabbed every 3 days?
Yes.
I wasn't aware they were doing that. Actually, we should have done it more than I experienced in NNU.
So the question is, as you can see maybe in the chat, why neonates are swabbed every 3 days? Yes, why? But if they're not, but why would they be?
Yes, I wasn't aware of that. I know they do it at birth, but not every 3rd day. But well, I've been here for 6 months, and there's a lot of things that I need to discover yet. It's a fantastic life being in the neonatal ward.
Prof, I think the question is if you have a neonate and you have a negative test, then you need to re-swab, or if you have a positive test, you need to re-swab them in 3 days. Why is it 3 days and not, say, 10 to 14 days later for a repeat test of the repeat test for corona? Right? I think that's the question.
I think it's I need to give a general answer to that. I think this is not evidence-based as much other procedures in neonatology, and I cannot answer fully on this.
Okay.
But it's an easy procedure, and if you are afraid and you have contacts around the baby, the newborn, it's easy to do that. So I guess it's It's like this. It was nasopharyngeal swabs I was talking about in my presentation, not eye swabs.
All right. Any other questions from the audience or through the chat? Well, I don't see anything appearing from the chat, so we can then. Oh, is there another question? I hear.
Yeah. Yes. I don't know if Can you hear me?
Yes.
Yes. This is Dr. Majan in Francistown. Thanks for joining. For making us join the group. That's a question maybe to Dr. Una Mulale. The guideline on the use of masks for children, I know that you said it's not recommended for children under 2 years. And I agree with that because that seems to be the guidance that we also see from the other countries. But our guideline as a country just says everybody should be on masks. I was struggling with a mother today who's got an 8-year-old child, and she has made a mask which wasn't fitting too well, and she was forcing it and saying that it is a requirement. You may be in the National COVID Committee. Is that really a requirement that all children, regardless of age, should have a mask?
So it is not. We have written guidelines that we have shared, but I don't think they've been published yet on the use of face masks in children. But our guidelines say that, yes, masks can be used, but if a child doesn't understand how to use them, they can cause more harm than good. So it's age dependent, it's also developmental age dependent, right? So you can have an 8-year-old who doesn't understand why they need to be putting on a face mask. So I think for children, their use, yes.
8 months old.
No, 8 months, no. No, and we have written guidelines that say below 2 years of age, definitely. 2 and under don't use masks. Above 2 depends on their understanding, but between 2 and 6, they're probably not going to understand. Above that age, they're probably going to keep it on for a little while and then just pull it off, you know. And if we're saying they should use them at schools, they're probably going to be, I want the Spider-Man one, do you want my Batman one? They're probably going to switch them around. But we have written those guidelines and yeah, we've submitted them.
Yeah, I think we should get them published because if somebody is enforcing that rule on the road, the mothers won't have much of a choice. Yeah, thanks.
Yeah. Okay, thank you.
Thanks to you. Thank you for that remark. So,
sorry, Peter.
Yes.
I just want to say hello to Dr. Majan and how great to hear his voice. This is Doreen.
Yes, the voice from the north. Perfect, thank you. Yes. So let me thank the presenters and the audience for your precious time to attend this webinar. Thanks also to Rutgers Global Health Institute for making this online meeting possible. And please stay tuned for the next webinar session, which will be on next Thursday. So thank you all and stay safe.
All right. Thank you.